Hello guys, actually I quickly discuss about the congenital disease of larynx. Then we see about the um, um, acute and chronic inflammation of the larynx, and then finally we see about the benign lesions of the larynx. Okay, I rush through each topic quickly. I'm trying to explain it clearly. Okay, then first we're going to say about the laryngomalacia. Okay, what is laryngomalacia? How can the child present is the child is present with difficulty in breathing. Okay, and the child will present along with the stridor. Okay, then you see how the pathology will be the cartilage, that is this soft laryngeal cartilage will be there. So due to this Bernoulli's phenomenon, the inspiratory air goes through this fastly, it creates negative pressure, so it is will become cartilage collapse, and then it became, okay, this is the principle. So this collapsed cartilage then became turbulent when the air flows, and this produces stridor, inspiratory stridor. Okay, any stridor that is occurring above the glottis or vocal fold is known as inspiratory stridor. Okay, the cause for this is during this negative pressure causes this inspiratory stridor, whereas in expiratory stridor it is in the subglottis region, that is below the trachea, that is in the trachea bronchi area, where the pressure from the chest all goes to the very small area, so it produces a stridor there. Okay, that is the cause for expiratory stridor. Okay, then okay, that's symptoms. Then when you see that, when you check the baby in indirect laryngoscope is contraindicated, so you should do direct examination. You can see omega shaped epiglottis and floppy or epiglottic folds, and prominent from prominent troits, floppy, and here is the epiglottis. You can see all this, and you can also observe stridor. Okay, then you can do other tests by you can get the child in prone position, the stridor improves as the anterior epiglottis comes to the anterior side, so the airway improves. So the management will be conservative, so under reassurance. Then this laryngomalacia should disappear by 2 years of age, as the larynx will grow after 2 years. Okay, this is everything about laryngomalacia. Next, let's go into subglottic hemangioma. Okay, how will the child present here? Okay, when you see this is also a vascular malformation. That is the pathology. Clinical picture is stridor only, one person only with stridor. Okay, at 3 to 6 months of age. So there will be inspiratory stridor present at this subglottic hemangioma. Okay, what's the pathology here is vascular malformation. It is increased blood supply to this subglottic region. So usually you think that in subglottic region there will be expiratory stridor, but here, and it's an exception in subglottic hemangioma, has inspiratory because of vascular malformation, pooling of blood due to negative pressure, increase in size. Okay, so this is the trachea, means pooling of blood here. So it is difficult for air to enter, so this causes an inspiratory stridor. Okay, then in direct laryngoscopy you can see reddish blue mass. Hemangioma means blood, so it is a reddish blue mass. Then RX is save the RFA trachea first, very must. Okay, if not obstructed. Okay, then CO2 laser excision or injection of steroid. Okay, very important to decrease the edema. Then laryngeal web, you can see both the vocal folds are attached. Here the child presents with hoarseness of voice and difficulty in breathing. Okay, so when you see the examination, you can see the web with the direct laryngoscopy. Okay, and also you can observe biphasic stridor from both the inspiratory, both difficult for both to come in and come out. So here pathologies in membrane pump is due to incomplete canalization of airway. Incomplete canalization is an absolute word, that's enough. Okay, then that may be types like congenital, is cartilaginous, then acquired maybe membrane formed. Okay, due to an infection like corynebacterium. Then long-term intubation can also a cause for this laryngeal formation, or iatrogenic. If you do any vocal cord surgery on one side, on both sides, it may attach themselves with the canalization, that is iatrogenic cause. Then treatment is CO2 laser excision with the silicone kilt. You should paste silicone kilt between vocal folds for wings to prevent recurrence. Okay, then you go into acute and chronic inflammation of larynx. First is the acute epiglottis. It is an caused by the Haemophilus influenza B, uh, which causes. So this is not highly recurred in developed countries, but in developing countries the vaccine is not still available as it's highly costly. So it will still be there. Okay, how will the child present? Okay, the child will present with okay, difficulty in breathing, dyspnea. Okay, then hoarseness of voice also will be there. Uh, this not be there. Okay, difficulty in breathing will be there, and difficulty in swallowing also will be there. Okay, these are the two prominent signs. Due to this dyspnea, the child will have tachypnea. Okay, child will breathe more like that. Then this will cause tachycardia. Okay, this is known as triploid sign. And also when you so this examination, you can see the rising sign or red inflamed epiglottis. You can see the epiglottis come above to till the uvula. This is known as rising sun sign. Another examination you can say is to open the airway. The child will sit in a position like this, so that the anterior epiglottis is moved anteriorly, so this there will be enough space for the airway. Okay, these are the signs. Then instrumentation is definitely contraindication, as this life threatening, as it will causes the closage of the larynx. Then diagnosis is X-ray. uh, Lateral view of X-ray, soft tissue neck. It confirms the thumb sign. Okay, you can see the thumb sign here. So it confirms the Haemophilus influenza infection. Then taking antibiotics is confirmed. Then antibiotics is ceftriaxone. Then steroid will decrease the laryngeal edema. Laryngeal edema is a very deadly. Then tracheostomy. If a laryngeal edema improved or obstructed high, then you can should do tracheostomy. Okay. Then some surgical procedures you need to know. Like first is the cricothyroidomy. This is an emergency procedure where you need to cut the membrane cricothyroid membrane that is between the thyroid cartilage and cricoid cartilage. Okay, you should palpate the what is that, Adam's apple, and you can feel a membrane below that below the Adam's apple, that is the cricothyroidotomy. You should do to preserve an emergency situation where outside the hospital there is no available of anything. If a blade also not available, you can do with a pen. Okay, then tracheostomy, its indication is very important. If there is respiratory obstruction, and there is respiratory collapse, there is respiratory secretions and respiratory insufficiency to secure respiratory pathway. So it's 5R. Okay, what are those 5R's? Respiratory obstruction, respiratory secretions, the respiratory collapse, respiratory insufficiency, okay, and obstruction. Procedure. Okay, between cricoid cartilage and sternal notch, you should do incision. It may be transverse or vertical. Usually in emergency procedure, this transverse is done, but it's but done in not in emergency, it can be vertical, so it produces no bleeding. No, so emergency means no bleeding, whereas okay, inside transverse or vertical, that's it. Okay, then inside between second and third cranial ring, you should do an head-shaped incision, or second and third cranial ring. Okay, then you should insert the tracheostomy tube. Complications include most common intraoperative complications: hemorrhage. Okay, prevented by vertical incision can prevent the bleeding, and but it has late healing, so it produces scarring. Okay, so it's a cosmetic problem, but it can be done in emergency procedure. Then most common post-operative includes subcutaneous emphysema. Okay, more post-operative immediate is emphysema, that's insufficiency of the respiratory insufficiency. Okay, next let's go into next infection is the acute laryngeal tracheobronchitis or group. It is caused by parainfluenza virus type 1 and 2. Okay, it occurs in children 3 months to 3 years of age. It produces the symptoms. Presentation will be barking cough, will be the presentation. Then fever will be along with that, and along with the hoarseness of voice. That is stridor will be the stridor. It's not hoarseness of voice. It's not used hoarseness of voice in only in vocal cord. Okay, then expiratory side stridor will be there. Then on doing the examination you can see subcortical intercostal retraction, you see. Then you can see the bilateral connector sound auscultation. When you see the x-ray you can see find the steeple sign, that is narrowed trachea, okay. Then RX is symptomatic, or you can give the antibiotics to treat the secondary infection, okay. That's it. Then laryngeal TB, okay. It's always associated with pulmonary TB, okay. There will be submucosal nodules. The most common area affected is the posterior part of the larynx, okay. Posterior part of larynx. See, this is the posterior part of larynx. Is the most common, where the first sign is the hyperemia of vocal cord with incomplete adduction. Incomplete adduction will be there due to the presence of the nodule. There will be incomplete adduction, okay. You can see. Then you can also observe the mammulated appearance of nodule, mammulated appearance. Then mouse nippled appearance of vocal fold. So you can see this mouth nibbled appearance of vocal fold. Then turban epiglottis. You can observe the turban epiglottis here, okay. So the nodules may causing ulceration and cessation, okay. The treatment is treatment of pulmonary TB. Then contact ulcer, the most common site is the posterior one third of vocal fold, okay. This also posterior one third. This is contact ulcer. The most common cause is laryngopharyngeal reflex, so you need to give PPI, okay. Speech therapy, reduce the hoarseness of voice. Vocal abuse will also cause this contact ulcer, okay. So the patient will present with hoarseness of voice. Then long-term intubation granuloma, okay. So for the intubation granuloma you should resolve often, so tube should be taken. Then antibiotics and steroids. Then let's come into the benign lesions of larynx. And the first one, so all lesions of larynx they present with hoarseness of voice. First link is edema, and due to misuse of speech or faulty voice, and also smoking. The space between this is a superficial pseudocytic squamous epithelium. Next to is the okay, and then a rinky space, and then there the edema will occur, okay. So it's known as, it will appear as a polyp, okay. So boggy spindle shaped vocal fold polyp, so it's called as smoker's polyp. It most commonly occurs in females, so the treatment will be cessation of smoking first option. Then stripping of the epithelium from vocal folds, okay. You should strip off the epithelium first, this pseudocytic squamous epithelium from the vocal fold, so it can heal. Then you should not do both at the same time, it may cause laryngeal, so you should do one at a time, okay. Then we come to the vocal nodule or single nodule or screamer's nodule. This is also counting misuse of voice. The presentation will be hoarseness of voice, okay. It's also in single stretchers, bilateral sessile, fixed free margin, okay, and say fixed free margin. Most common site is the junction of anterior 1/3 and posterior 2/3. Say anterior 1/3 and posterior 2/3 junction, okay. It is the area of maximum vibration also. The patient present with hoarseness of voice, then treatment is speech therapy. You should tell him to speak at low voice and not shout. And then PPI, if the laryngophageal reflex is there. Then soft nodules, alien soft nodules can heal with the speech therapy and PPI, whereas hard nodules you should not involve only in the speech therapy and PPI, okay. You should do okay, if it healed, no problem, but if it's not healing again, recurring again, is not changing again, you should surgery, and again you should do speech therapy, okay. Next is vocal polyp. You can see a polyp here. It is a single unilateral pedunculated, so pedunculated means it's a collection of fluid, so it will move in respiration. This will appear as it will move down, up and there. Then causes sudden vocal abuse, okay. Suddenly if vocal abuse there will be capillaries will be broken here, and this Bernoulli's phenomena causes this inward pulling, so it causes the polyp here. The presentation will be hoarseness and diplopia, okay. It appears here as double frequency as mobile, so mobile it causes double frequency. It's a clinically presentation. Then surgery will be microlaryngeal surgery, okay. you can cut this microlarynx surgery. No therapy as is often because already she is a soft speaker. Then recurrent respiratory papilloma, it is caused due to a human papilloma virus infection, 6 and 11. Okay, the child is most common in child, and also in the child is juvenile. Then adult. In adult is limited, single unit does not recur after recurrence, it's soft there. But in juvenile, it's very important. It's a juvenile recurrent respiratory papilloma. It is multiple. Okay, multiple. Then bilateral, stridal present. Then highly recurrent. Okay. The child may transfer it through vertical transmission, the most common cause. Okay, during it occurs during the delivery of child. Okay, then tracheostomy is common in children because there is risk to spread to bronchi and lungs, but in emergency low tracheostomy can be performed. Okay, then treatment is the cold still infants, bleeding and scarring, higher recurrence to be there, so it also should be used. The only you can use is CO2 laser section, it has very less recurrence. Then micro debrication now performed. Okay, the cutting bleed also put suction. Okay, then medical management you can do. The CO2 layer is also not used because it forms spread to it produces fumes. The fumes contains HPV, so it can spread to the operating surgeon also. Medical management includes chemotherapy. Then you can do the photodynamic therapy. Phototherapy is nothing but it is dihematoporphyrin DHC. It's an inert substance. It goes and acts on the papilloma and the papilloma virus cells. Then you should give 50 joules of 630 nanometer of argon laser light, and it gets activated and becomes toxic to cell and kills the cell. Okay, so it is an available treatment. Then interferon alpha, okay, which can act as antiviral, anti-proliferative, immunomodulator. It has multiple actions. Then you can use anti-VGF like bevacizumab. Then cyclosporin, ribavirin, antivirals. Then you can also use zinc therapy prevent recurrence. It is observed that the patient who are having a recurrence have low levels of zinc. Okay, then this juvenile recurrent respiratory papilloma has high tender to become squamous cell carcinoma of larynx. Okay, then the last one is the vocal cyst, is the collection of fluid. Okay, in the vocal fold. Okay, treatment will be microlaryngeal cell section. Okay, during the surgery only we can differentiate whether it is lipoma or a vocal cyst. Diagnosis is made during surgery. Okay, thank you very much.